Welcome to Sex on the Floor podcast. This podcast was created to help educate the public about problems with sex and intimacy and how this is tied to both physical and mental aspects. Hosted by myself, Dr. Molly Hart, a passionate pelvic floor physical therapist and owner of Pelvic Balance Physical Therapy, and by Dr. Katie Schubert, a phenomenal sex therapist and owner of Cypress Wellness Center. We are here to have a good time. We're here to keep it real with you all and to educate along the way. I'm so excited for you to join us. We strive to help many relationships prosper in fun, safe, and healthy intimacy. While listening to the show, please remember that this information is not meant to diagnose or treat any medical conditions. Please speak with your medical provider for all things related to your healthcare. Hello all, welcome back to Sex on the Floor podcast. We have a treat today. We actually have a guest on, which is exciting. So it's myself, Dr. Molly Hart. We've got Dr. Katie Schubert here. And today we actually have a guest, Heather Florio. Am I saying that correct? Yes. So I will do a little intro about Heather, and then I would love for you to tell our listeners a little bit more about yourself. But Heather is somebody who comes to us with a lot of experience, specifically with interstitial cystitis, which so far our listeners, that's painful bladder syndrome. We're going to get more in depth in this episode about her expertise in this area. But she is a pelvic and sexual health advocate. She's a second generation CEO of Desert Harvest, which is a company that's trusted by clinicians in 50 plus countries for interstitial cystitis support. So she's known for making taboo topics easier to talk about, especially chronic bladder pain, pelvic pain, painful sex, and she's why so many women struggle for years before getting real answers. She's able to help talk about these things. Desert Harvest Aloe vera protocol has gone through clinical studies reporting 92% symptom relief for IC patients, and it's currently undergoing FDA approval. So I'm excited to talk more about that with you. It's the first non-pharmaceutical treatment for IC, and that's a really cool thing because it's at a time right now we know that the main go-to option for IC is Almiron. And as we know, that's facing a lot of lawsuits tied to eye damage and other issues. I know a lot of my patients have had so many issues with Almiron. It's not my favorite thing for people to be using for IC. Some things that we'll hopefully cover today is why recurrent UTIs and pelvic pain are so often misdiagnosed and why the medical community, it's so interesting how the medical community treats that, and what women can do to get answers sooner. The bladder and the bedroom connection, why IC can trigger painful sex, low desire, and relationship stress. Like that's a big thing I want to hit on today because that's huge for, I would say, our listeners. Huge. And then the Aloe story, what the research shows and why the FDA process matters right now. So I'll leave it kind of right there, Heather, and I'll let you take it from there if you want to introduce yourself to our listeners beyond what I just said.
Yeah, definitely. So my name is Heather Florio. Like you mentioned, I'm the CEO of Desert Harvest. We have been specializing in predominantly women's pelvic and sexual health since 1993. You can imagine way back then, interstitial cystitis was a condition that was all in your head, did not really exist, such as, fibromyalgia, other conditions like that. And so we really had to fight and advocate for women over the past 33 years to make this recognized condition, to get the research done that proved that this was an actual condition. And we're still working really hard to deal with the muddied waters that are interstitial cystitis. Unfortunately, there is a high rate of misdiagnosis with interstitial cystitis because in the US, we do a bit of a disservice in the fact that we do it as a diagnosis of exclusion.
Yeah.
And the rest of the world does it as a diagnosis of via cystoscopy. And so as a result, women suffer for a very long period of time.
Yeah, absolutely. Do you want to, for some of our listeners that might not know what IC is, and even what a cystoscopy is, do you want to explain what that is?
Yes, no, definitely. So interstitial cystitis is you have a red inflamed bladder. You have lesions that the urothelial cell layer of your bladder, that lining, it's a protective coating that's naturally in your bladder so that when things pass through, they're not irritating your bladder itself. And unfortunately, in these patients, that layer is degraded, and as a result, the gag layer of the bladder, and so as a result, anything that passes through there, any type of thing is going to be an irritant to the bladder. So this is where diet comes in, reduces acidity, things like that. Interstitial cystitis affects 8 to 12 million men and women in the United States alone. And so a lot of the times for women, you're diagnosed many times with recurrent UTIs before you actually end up with a diagnosis of interstitial cystitis. It's almost becomes that diagnosis of exclusion, like I mentioned. A cystoscopy is typically the way in which this is diagnosed, and this is where they actually stick a camera up your urethra into your bladder. It is not the most comfortable procedure, which led to people doing it less and less and less. But it currently is and especially if you have interstitial cystitis, a lot of the times it leads those IC patients into a flare. So
Yeah.
unfortunately, it's one of those things that we have kind of veered away from in the United States, but everywhere else in the world, it is the only way that we diagnose interstitial cystitis, and the rest of the world is putting a camera up there and looking for true bladder wall impact. And then if you don't have bladder wall impact, then we start looking at other things. There are many evil twins to interstitial cystitis, including endometriosis embedded on the outside of the bladder. And so there are a variety of different things from overactive bladder. There was a recent study that just came out this year, and we're actually really excited because it actually shows it was actually studying the microbiome of both the bladder and microbiome as well as the vaginal microbiome, looking at the differences between those that are healthy and those that are unhealthy and have regular recurrent UTIs, bacterias, other things like that. And they found in overactive bladder patients that they had unhealthy microbiomes, both urinary and vaginal. And so we're really excited about that because that could potentially lead to some difference for people that aren't necessarily suffering from interstitial cystitis, but suffering from overactive bladder or other conditions, bladder endometriosis, pelvic floor dysfunction, radiating pain from neuropathy from another condition. And in fact, one of the hardest things that's been over the years, as we started roughly early 2000s to veer away from doing cystoscopies, and as a result, we just started this diagnosis of exclusion. We're going to rule out you don't have endometriosis, you don't have this, you don't have that. So and your recurrent UTIs keep happening, so you must have interstitial cystitis. And unfortunately, what that done is allowed a lot of people that do not have interstitial cystitis into kind of this group and trying all these random treatments and other things, and nothing's working, and we don't know why. As women, we have so much going on in our pelvic floor, pelvic region alone. It's our hammock. It's holding so much, our pelvic floor, and we do it a disservice. There was finally actually a study done, and interestingly enough, I think it was 23, and it was utilizing Dr. Lenore Ackerman at UCLA, utilized machine learning AI. And she took all of the patients at UCLA that were suspected of, they have a large percentage of potential interstitial cystitis patients that come in. So every one of them, they would fill out questionnaires and they would lump them into this system, and it would learn and it would learn. And for the first time, we actually there's always been theories from doctors. There's organizations that have put up theoretical ideas of subtyping and everything like this, but we actually have no true medical evidence to show this. And so this was the first time that we actually got some evidence showing three distinct groups with very little overlap. And now they're expanding this into a
Okay.
larger subset of patients right now because in those groups you found all myofascial pain, pelvic floor. So all their pain was coming from their pelvic floor. You had the bladder centric group, which means all their pain was coming from their bladder. And then you had this third non-specific pain, neuralgia type pain group. And so
I'm
now we
not
have three.
surprised by that at all. Based on like clinically
Yeah.
what I've seen, I'm just not surprised to hear that at all. Okay.
Yeah. And I mean, if you just get that one, 88% of that myofascial group resolved with pelvic floor physical therapy. We know that the neuralgia type pain, like if you have a back injury and the pain's radiating and it feels like you're having bladder symptoms from an injury maybe in your low back or something like that, that we know that could spur urinary symptoms, but that doesn't mean your bladder is the culprit. And
Right.
we have options out on the market, amitriptyline, other drugs like that, that go directly to the nerves, gabapentin, other things that are on the market that interstitial cystitis patients can talk to their doctor about if they think it's not interstitial cystitis and it's that radiating neuropathic pain. And then that bladder centric group, that is the group we really need to study and we really need to understand. If you have the lesions in your bladder, there are options where we can ablate where those lesions can be ablated. But if you just have this red inflamed bladder, there's not a lot of options. You mentioned Almiron, and yes, they're undergoing class action litigation right now in both the US and Canada for causing retinal myopathy, making people go blind. And then also, they're actually now researching potential causing IBS in
Hmm.
patients that have been taking it. So what Almiron does is they synthetically coat the bladder
Hmm.
with like a gag-like molecule, but it's all synthetic and chemically made. With Desert Harvest SSAV, and this is the one that's currently undergoing FDA drug trials at Wake Forest University with Dr. Robert Evans. And we are actually studying how we've always theorized because aloe vera is very concentrated in glycosaminoglycans. This isn't, now just understand this desert harvest is not the aloe vera you go find in the health food stores. You don't go drink some aloe vera and think it'll be great. Aloe vera naturally has compounds in it which cannot be safe for long-term use and in high doses. And that is exactly what we are doing. We actually follow it all the way from field to bottle. So when we're harvesting our aloe plants, we're processing them within 20 minutes because the minute you cut an aloe leaf off of a plant, malic acid begins to eat away at the nutrients. And then there's nothing left. It's just expensive water after about 6 to 8 hours.
Hmm.
And so within 20 minutes, we're processing our aloe vera to preserve those nutrients. We're processing the entire leaf. And because some of the best nutrients are actually in the rind. But then there is anthraquinones. These are compounds naturally in aloe vera that act as a spasmodic, an irritant to the colon.
Hmm.
And when you see words like on aloe vera that says digestive aid, things like that, that's because what that's meant to be used for is short term as a
Okay.
quick digestive aid or for the nutrients in the aloe vera. But what we are doing is we are trying to maximize, we grow at the base of a volcano so that we increase the nutrient content. We process within those 20 minutes so that we're preserving those nutrients. And then we're concentrating it through our patented process. And it roughly takes 89 full grown Aloe barbidendis Miller leaves to make one of our 180 capsule bottles of our SSAV. So you think those, 4 5 foot long leaves, that's 89 of those for one bottle. And that gives you an idea. We're processing out that there's naturally fiber in aloe vera. That's part of what we're also taking out to make sure that that's not acting as an irritant to the colon. And then we're going a step further. We actually utilize a little bit of calcium in every single to make it as alkaline as possible for the bladder. So what we theorize it's doing is synthesizing the coating in the bladder.
Okay.
So the glycosaminoglycans. But then what we're studying now is the mechanism of action of the aloe vera under of our SSAV underneath that layer, because we know that there's over 200 nutrients naturally in the aloe vera plant, active enzymes, antibacterials, antifungals, antimicrobials, anti-inflammatories, analgesics. So we're trying to understand exactly how it's interacting with the urothelial cell layer of the bladder and what that mechanism is actually doing. And so we're actually harvesting urothelial cells from each patient that's part of our study. And we are actually understanding the beginning and the end. We're doing everything from liver function, kidney function, thyroid function, every CBC test you could think of. Like we are doing it all, and then some in this particular. So this is the most extensive study we have ever done. We're watching the pharmacology of how it actually processes and interacts with all of the components in the body.
So this is mainly then going to be for those patients who are actually having true bladder symptoms then, and actually the bladder, because I see so many people who come in with a diagnosis of IC. Well, they might even,
Hmm.
I mean, gosh, so many people don't even have a diagnosis.
Hmm.
They should have a diagnosis, but they don't. But it's not actually the bladder that is the problem. It's a lot of the times it's actually the nervous system that's more irritated, I would say, than
Hmm.
anything. It's the pelvic floor muscles, but I feel like you can't even separate it all because the whole body at this point is so irritated. The bladder
Hmm.
is involved, the nervous system's involved, the muscles are involved. um, and I would say maybe 10% of my patients that I see, I'm like, no, your bladder, the bladder itself is actually involved here. So this
Yeah.
is something that is specifically designed for those patients where the bladder is actually involved and the lining is irritated. And
Yes.
what is the protocol? Like, how often are they taking it? What does it look like?
So, in our double blind placebo controlled studies that we've done over the past 33 years, we have developed a dosage protocol based off of that. Six capsules a day for the first month.
Okay.
You can ramp up from there. So, we have, if you don't find your full level of relief in the first month, the second month, you can up to nine, the third month, you can up to 12. But then after those, but you can stay on six the whole time. But the goal is to stay on six for 3 months
Okay.
minimum. And then from there, at 3 in the morning, three at night. And then you can maintenance dose down from there and find by taking away a pill a week and seeing how your body adjusts to that. If you feel any of your symptoms return, you would return to the previous dosage, and that would be your long term maintenance dose. Most people maintain on 1 to 3 capsules a day after those first 3 months.
Okay. Wow.
I have a really
Yeah.
basic question. I
Yeah.
don't live in
Yeah.
the same world as the two of you. So I think that a lot of our listeners will also have the same question.
Yeah. Go, Katie. I love it.
Um, so you guys are both saying that IC is often misdiagnosed as recurrent UTIs. Do they feel the same?
Yes,
They
that
feel the
is so
same.
the hallmark symptoms for interstitial cystitis feel like a UTI that the most painful UTI you've ever had that never goes away. So
Yeah.
frequency, burning, pain are and nocturia are the hallmark symptoms, and that's what we're studying when we as hallmark symptoms when we're doing our clinical research.
Yeah, Katie,
Okay.
it's so frustrating. So my patients that come in, it's so frustrating. Now they don't understand all this that we're talking about.
Mm-mm.
Okay.
They haven't gone, nobody's explained any of this. So they're like, I have a UTI. And I'm like, I don't think you do have a UTI because this is, their fifth UTI in this year and it's only February. And then they're like, they're on their fifth round of antibiotics. And they're like, it's not going
Mm.
away. And I'm like, okay, well, I'm like, have you actually tested positive for an infection? And they're like, well, no, it's not coming back positive. And I'm like, well, because I don't think you actually have a UTI. And they're like, well, why do I have these symptoms then? And they're like, well, it showed high white blood cell count on the microscope. And I'm like, well, they don't even say microscope in the clinic. Well, that is super inaccurate when they go in and they look at that.
Mhm.
That's the most inaccurate thing ever. And I'm like, well, did you actually get it cultured? Half the time they're like, no. And I'm like, you have to get it cultured. It has to
Yeah.
be cultured. And I'm like, when did the culture come back? Oh, the culture came back and there was no infection. And but they still get prescribed an antibiotic. Now that's starting to not happen anymore. Doctors are starting to actually not prescribe an antibiotic unless there is actually a positive culture. I'm starting to see a shift in that. Thank God that's starting to happen. That was not the case even a year ago, and especially like
Mhm.
earlier on in my career. So it's really frustrating because it presents the same. But what I do is I teach my patients to understand why they're flaring. So, like for instance, I just had a patient the other day text me, which is so awesome. I love this so much. She just texted me. She's somebody who would present like with IC, and she goes, I can't tell if I'm having now she does sometimes though have an infection because sometimes they do have infections because they are prone
Mhm.
to infections because they're so
Yes.
restricted down there. So they don't know. She goes, I can't tell if I'm having an infection right now or a flare. And I go, well, tell me this. I go, when did it start? She goes, it started yesterday. I said, well, what happened the last 2 days? I go, did anything different happen? Did you increase your exercises? Did you do more legs or core? Did you go get a massage, like a deep tissue massage? Did something really stressful happen? Did you have an increase in sex or more aggressive sex? Did you eat something really acidic? She goes, I just got a deep tissue massage for the first. I said, was that the first time you had a massage in a long time? She goes, yeah, I haven't had a massage in 2 years. I go, you're just flared. I go, you probably don't have a
Mhm.
UTI. And I go, do all this. I have like a flare protocol. I said, do all of this. I said, text me in 2 days. If it's not calm, then go get tested. You probably have a UTI. I said, but it's probably just a flare. She texts me 2 days later. She goes, yeah, you're right. It was just a flare. So like
Mhm.
there's ways to, but they don't know that. So if she didn't have a pelvic floor PT and ways to calm it down, they freak out, and then the anxiety will cause it to ramp up even more. And now I don't know what's going on, and I'm going to go get on another round of antibiotics. And antibiotics also decrease inflammation. So when I go take an antibiotic, it does help temporarily, a little bit, calm my symptoms, even if I don't have an infection. So then it's so
Mhm.
confusing. Like
It is.
My my other question, my other
yeah,
very basic question. You guys both said that if you have IC, having penetrative sex can be painful.
Mhm.
Is that just because you're inflamed and uncomfortable, or is there something else?
It's usually, I'll let you kind of take this one a little bit more, Katie, but it's probably the hypertonicity of the pelvic floor. Your pelvic floor is probably like a dish rag that's wrung so tight because you're in this chronic pain state. Your nervous system is upregulated, and so you're just
yeah.
tensing everything.
Yeah,
I
it's really the way the nervous system is. So I always tell everybody nerves love three things. They really love a lot of healthy blood flow. They love to have space around them, and they like to be able to move freely in the body. And so when we have something like interstitial cystitis, you're not getting good blood flow because everything is so restricted. So everything's so restricted, and
Mhm.
blood flows via pressure. It's a pressure gradient. So if I'm really restricted, I'm not going to get good blood flow to that area. If it's really restricted, my nerves are having a ton of pressure around them. Nerves hate having a lot of pressure around them, and they're not able to move freely. So the nerves in that area are pissed off like no other.
Mhm.
Muscles don't transmit a message of pain, or a nociceptive message, I should call it. Um, Sorry, my computer right now is my camera is messing up and it's bothering me.
Mhm.
Um, but so I'm getting distracted over here. Sorry. So, intercourse, if we have something now where I'm like pounding on these tissues, the
Mhm.
nerves are like, what the heck? It cannot handle that. So if you think about it, if I have like
Mhm.
a knee injury and then I go and I just start running, like I'm pounding on it, it's going to piss the knee off, right? So sex is just, it's too, the nerves are already so pissed off and irritated. Any type of extra pressure and movement on those nerves is going to flare the shit out of it. I mean, and sex really flares them so badly. And even an
Mhm.
orgasm, even if they're not having sex and they just masturbate, masturbation and an orgasm is also going to flare them. And it's typically, it might not even be that day, but the next day and the day after that will be really bad. And and sometimes women don't realize it. They don't even realize
Mhm.
that sex is causing the next couple days for the bladder just to be out of control until they come in and see me and I'm like, hey, have you noticed this correlation? And they're like, oh, yeah. So,
Yeah. Yeah, if they're not addressing that hypertonic pelvic floor, then they're just, when they're orgasming, a lot of times, you orgasm it tightens and then it releases, but for so many IC patients, it just further tightens and
Yeah,
you're not getting that release that you should after orgasm.
yeah,
And that's why it's really important to address the hypertonicity of your pelvic floor before having sex, especially when you're an interstitial cystitis patient, let alone the fact that the external urethra can be very irritated from that burning sensation and they
mhm.
just have that constant burning sensation. And so like one of the products we have that a lot of PTs actually use is the Relivium. It's a patented blend of plant botanicals that was developed for vaginal cancers. And it was with the idea of radiation dermatitis. So it has 4% lidocaine in it.
Oh, okay,
And
good.
the women love to use it on the external urethra and then utilize it on the vestibule in combination with a water-based lubricant like our Aloe Glide to be able to have comfortable sex. So that's kind of one of the tricks of the way around it that a lot of our customers utilize.
Oh, I love that. Yeah, lidocaine's a big one that people will use.
Yeah.
Some women
I
will use
just,
that before even coming to pelvic floor PT. In the beginning,
yeah.
like if it's really
Hmm.
painful. I sometimes I use it. Sometimes
Yeah.
I've had like mixed results with lidocaine. It depends on the female.
Yes.
Um,
I always recommend don't put it down there till you try it right here. This is going to be as thin as your vaginal tissues, and this is a
ah,
good test for you right here in your inner elbow. Put it there and test it there to see if it irritates or burns before you put it down there because there are a
yeah.
lot of people with lidocaine sensitivity and it may not make sense for you.
Oh, I love
So it's,
that. I'm gonna use that. Yeah, because some women love it,
yeah,
and then some people are like, "Oh my
uh-huh.
gosh, no!" It's like it burns and
Yeah,
makes it worse. That's
yeah,
good. That's a good analogy. I like that,
yeah.
or a good
Well,
reference point.
and the Desert Harvest Relivium, what makes it typical than a typical lidocaine gel? So a typical lidocaine gel in research lasts maybe 1 to 2 hours. In research with the Relivium, because again, our aloe vera acting as a carrier to make it more systemic and long lasting, we on average see 4 to 6 hours.
Hmm,
But you can reapply every three.
gotcha. Heather,
So
when is your product going to be ready for you think the market and FDA approved, possibly?
Well, it's on the market. It's been on the market now for since 1993. It was our keystone product that
Oh,
started our company. We've done tons of clinical research, but when everything started happening with Elmeron, we actually got asked to proceed down this path.
gotcha, gotcha, gotcha.
And Dr. Robert Evans has been amazing. We're a small family company. We're not a pharmaceutical company. So making this possible for us was something Dr. Evans really wanted to advocate and make happen. And because he cares about his patients and he wants to give them options. And all these clinicians didn't have anything else in their toolbox from a pharmaceutical perspective other than Elmeron and maybe a little, your Gesic Blue and maybe a little amitriptyline here and throwing a little things that may not be, but the only thing that was indicated for interstitial cystitis is Elmeron.
Right.
As far as the pharmacologic goes. And so Dr. Evans has been wonderful in really believing in the work that we've been doing for 33 years and helping us proceed down this path as a small family company.
Gotcha. Katie, do you have to go right now?
I do have to go.
Okay.
I want to say how impressed I am with you guys saying this word so many different times because I don't think I could say it once. I'm just gonna
Yes, you
resort to
could. Yes, you could. You know what's funny? When I first became a pelvic floor PT, my first patient who came to me and said, interstitial cystitis, I was like, what? And then she said IC. And I remember I was like, I think I like tried to write it down on paper and I was like, what is this word? I remember thinking that too. I was like, I was like so man, being introduced to the pelvic health world as a new grad, I was it was a whirlwind. And it's funny being on this side of it now. So
Mhm.
I understand Katie. But I'm gonna stay on with Heather and
yeah.
because I want to Yeah,
I
go.
have one more basic question before I leave because you guys are you're both amazing and you're talking on the same level. If I let's just say if I have recurrent UTIs and I suspect that I have IC, who do I go to get diagnosed?
In my opinion, so a typical referral is going to be right to urology.
Okay.
Hmm.
I would ask if you're a woman, I would ask for a urogyn because they're going to understand the female anatomy and they're going to go a few steps further than a typical urologist. Urologists are typically the ones that are a little bit more dismissive if they're just pure urology. And they're also the ones more, they're looking for the surgeries, the things that they can fix, not the chronic pain patients. They're looking for the kidney patients, they're looking at a completely different complexity. So they don't necessarily want the chronic pain patients that they can't fix and send out the door.
Okay.
Yeah, Urogyne is who you really want to go to. And if you're gonna go to urology, I actually, man, and
Mm.
where I'm at, urology is so bad here.
Oh,
There are some really good urologists that I do refer to.
mhm.
They're all females, I'll be honest. Like the female urologists are just so much better than the male urologist. It sounds so bad to say, but it's true. I don't send, I have two really phenomenal urologists in the Tampa Bay area. One is Dr. Sterling's and one is
Mm.
Dr. Marguerite. I can't remember her last name, and they're the only people I send both my males and females to. But there's a couple of Eurogynes here. And even the Eurogynes, I'm going to be honest, they're great, but sometimes they're even dismissive with
Mhm.
interstitial cystitis. And they're kind of quick to sometimes jump to more extreme protocols and not follow the American Urology Association recommendation for IC. Like there's a protocol to follow for grade
Mhm.
A, B, C evidence, and sometimes they skip and go to more extreme protocols. Sometimes so that's frustrating for me as a pelvic floor PT. So I would say number one,
Yeah.
get a really good pelvic floor PT on your team if
Mhm.
you think you have any of these types of symptoms. And how do you know you like look at reviews because not all pelvic floor PTs treat chronic complex pelvic floor pain. So
Mhm.
that's important. Like there's some that are really good at treating intense athletes, and there's some that treat chronic. Like our bread and butter is chronic pelvic pain conditions, is IC and stuff like this. And then we have some pelvic floor PTs in this area who are phenomenal at treating CrossFit athletes and pregnancy and postpartum. So like do your research
Mhm.
and what you're looking for providers if you are struggling with this, I would say. So that's a good question, Katie, because it's
Yeah, because
hard.
like you mentioned the AUA guidelines, the first line of defense is pelvic floor physical therapy. That is
Yep.
the first thing on the AUA guidelines for interstitial cystitis. So,
Yep. So you said your product's already on the market. So your product is, can you specifically spell out like what your product is and where people get it from? Like how they get it?
yes, so that is our SSAV capsules. That is our what we have developed specifically looking for interstitial cystitis that we've been doing for 33 years that is currently undergoing the FDA drug trials. And that is available on our website, desertharvest.com.
So desertharvest.com and it's called S.
SSAV capsules. It actually stands for super strength aloe vera, but we made it an acronym because we're like, that's a mouthful.
Okay, so SSAV capsules. And
Hmm.
the instructions you gave was 6 capsules, 3 in the morning, 3 at night for the first 6 months, is what you said on here.
3 months.
Is that written on there? Is the protocol written on there?
Yes, so if you order from us, you're going to get a catalog which details that dosage protocol, but it's also on our website. You can just search SSAV dosage protocol and you'll be able to directly find it. It is under our Learn tab, but sometimes I just find things easier to search. And so, but yeah, that details everything and includes a flare dosage protocol. So if
Oh,
you
good.
are having those
Oh, I
stressful
love
moments,
that.
you
Okay.
eat something that you're not supposed to. So that is an option. If you are not experiencing interstitial cystitis or you are experiencing recurrent UTIs, just so you know, we do have a new product. So typical standard over the counter is D-mannose.
Yeah. Hmm.
There's already mannose and aloe. You're already getting it. You don't need to take additional.
I was
And
going to ask
then
you about that. I have some other follow-up questions. Okay, good.
oh, perfect. And but In clinical research, D-mannose only binds to E. coli bacteria and flushes it out as a preventative. We actually just introduced our Heather's UTI defense, not because my name is Heather, but from the heather plant, the Calluna vulgaris plant. In our clinical research, it binds to 3 different bacterias, and we are studying 2 more in clinical research right now at Oxford University to see if we can actually affect more than just those 3. And we have 2 potentials that are on. So all of that information is on our website. It's called Heather's UTI Defense. You get triple the protection of D-mannose in clinical research. This all the information is on our website about that research, everything, and
Can
the
I ask you
different
what the three
bacterias.
bacteria are?
It's the so E. coli, of course.
Okay.
What is it? The P. fascialis, and uh, you're going to quiz me here.
Well, I'm just
I'm
curious because I
trying to.
mean, obviously, E. coli is the number one that shows up, but there's also some common
Yeah.
ones that always show up. So I'm curious what three it's binding to.
Yeah, so the 80% of UTIs are accounted for by the by E. coli bacteria.
Yeah,
80% are E.
I
coli.
know. But then
And
I've
then
got my patients who come in with these like crazy bacteria. I mean, they're and then
yeah.
yeah.
Oh, and the third one is P. vulgaris. I had to look it up
Okay.
really quickly. So E.
Okay.
coli, E. fascialis, and P. vulgaris.
Okay, very cool. And then
Yeah.
okay, so then what about because other things that I really like is marshmallow root. Do you
Hmm.
recommend using marshmallow root with this? Is that safe? Marshmallow root.
Yes, we have a
Okay.
lot of people that jump right onto marshmallow root.
And they can use that with both of these products.
Yes, yes, there is no reason. We have been successfully using marshmallow root. We have never done it ourselves just because dosage can get a little dicey on the marshmallow root. So we've never made one ourselves. And if you're on the SSAV, it usually handles it. But if you want an additional tool in your toolbox, marshmallow root is good. The other one is quercetin. And that is for that. So not every interstitial cystitis patient has this, but for the mast cell activation
Yeah.
component, we call this the allergic bladder.
I love
And
that you said that. I love it because I just had somebody on TikTok do this whole thing that I we were posting about the American Urology Association guidelines, and somebody
uh-huh.
posted that like every IC patient has mast cell activation, and it was just, and
Oh,
I was like, oh my gosh, I was like, no, they don't.
no, no,
I shouldn't get annoyed by this stuff, but I was like, but I do because I'm like, no, they don't.
no, they don't.
Like, I was like, it is not a one size fits all. So I'm happy you said some patients. So
Yes.
yes, go on.
And I think this is how we're going to end up with subtypes within that bladder centric group because we do have these that are mediated by more inflammatory cytokines and that mast cell activation component and histamines that are more affected by that. And that's where quercetin makes sense. This would be like your natural antihistamine,
Okay.
essentially. A lot of the times, prescribing is usually hydroxyzine,
Okay.
is usually the over counter. The only side effect to that is have fun waking up in the morning.
Yeah.
But
Yeah. Yeah.
and don't take that during the day. So, but other than that, there is also a probably, you've also got this hormonal component. So let's talk menopause here because
Yep, and genitourinary syndrome is a huge factor. And
yes.
it's not even, you know what, it's funny too, is and I love this. So I was just telling Katie this, and we're gonna do this on an episode soon for any of our people listening, is we're gonna do an
Mhm.
episode very soon here on menopause and perimenopause, and then we're gonna do one on hormones specifically. But I love that they're starting to do this in the research, is genitourinary syndrome of menopause,
Menopause.
of breastfeeding. They're starting to do that in the
Lactation.
research,
That I was
right?
just at Ishwish while in Long Beach, like
Right.
looking at the new research being presented on lactation.
And then I want them to do one. I would like genitourinary syndrome, a birth control. Honestly, I do because
Mhm.
I have noticed that my patients who are on birth control, I'm also seeing like I'm starting to see some differences even in my young females who are not they're not going through perimenopause, they're not in menopause, but they present, or sorry, of not birth control, of endometriosis. I'm seeing like
Uh,
other classifications of women who present just like genitourinary syndrome, the exact same presentation, but they're younger. So I'm like, I think we can
mm-hmm,
say there's genitourinary syndrome, and we've got these different classifications, but I think as time goes on and we start to study female health more, we might notice different classifications of that and how hormone therapy can help with multiple different subsets. Because what do we use? We use birth control for endometriosis. They use that.
mm-hmm.
So that's why I was
Yes.
getting my terms mixed up. But so I'm interested to see how the research changes throughout the years on women's health
Mm-hmm.
with all of this and hormones specifically for painful bladder syndrome, for interstitial cystitis, for overactive bladder. There's a huge component in that that we cannot
Mm-hmm.
ignore.
Mm-mm.
Yeah.
Oh no, not at all. And actually, we have a newer product. So the one of the biggest things that's going to make a difference, obviously, when you're in menopause, because your bladder lining is going to just naturally degrade if you're not on hormone replacement therapy. And so that is where the importance of hormones come in all of these levels. So I think that hormones is going to play a huge role. And we just came out with this new product. It's human bioidentical lactoferrin. So this is human lactoferrin. It's the world's first. Everything out on the market is bovine. So this is what is naturally in the colostrum, the glycoprotein in those first few months of life, those building cellular building blocks that bodybuilders pay for breast milk on the black market to get kind of
Mm,
thing. Because
okay.
bovine isn't going to function the same way in the human body, obviously, as a human version. So we created the first human version where we don't have to go extract from a woman, and we were able to replicate it directly from a woman. And so, what this is going to do, lactoferrin is an iron binding glycoprotein.
Okay.
So, what its primary goal is to create iron homeostasis in the body.
Hmm.
So, when you're menstruating, your iron levels drop.
Right.
So, you need to bring them back up to homeostasis. When you are in menopause and you're not menstruating, your iron levels increase and go up because you are not menstruating anymore.
Okay.
And so the lactoferrin creates iron homeostasis in the body in our clinical
Almost acts like a
research.
base or like interesting.
Yeah, so when we talk about creating iron homeostasis in the body, you are affecting so many different things from your immune system, your cytokines, your inflammation in the body, inflammatory cytokines, as well as estrogen production. So if your iron levels are going too high or too low, you're affecting your estrogen production. So
Interesting.
if you create iron homeostasis in the body, you're creating
Just
estrogen
more of a balance.
homeostasis. Yes,
Okay.
yes, you are optimizing estrogen production in the human body, as well as, and we are actually studying this right now. You mentioned endometriosis. We're actually studying it for endometriosis
Okay.
because we are theorizing that the stomas, the lesions, of that are endometriosis, the stomas, the endometrial tissue, that they are feeding off of the iron in the peritoneal fluid that sits in our abdomen, and that we can affect
Take away the feeding
how,
source, essentially.
yes,
Okay.
uh-huh.
How do you,
And
so this that you, so is this like this is a hormone then that you're creating?
no, this
The
is
lactoferrin?
lactoferrin. This is an
Lactoferrin
iron
is a
binding glycoprotein.
it's a protein. So this protein, how then does how do you get that in your body? Is it a
Pill.
it's a pill. Okay. That's what I was
One
trying to understand.
once a day is all you need, with what we have created, and then we add a little bit of our aloe vera, our SSAV, to every single one of our supplements, because in our clinical research we've shown that we enhance bioavailability, or how it's in your body,
Absorb. That's what I was
systemic,
gonna say. Yeah.
absorbed. Yeah, 25%. It increases bioavailability by 25% in the
By
body.
putting the aloe vera in there.
Mm-hmm.
Wow. Okay. Interesting. It's
Yeah.
so cool. Okay. So you already have the product on the market. I guess my other question then is, because you just said there was this study that was done at UCML. Where was it done at? Where they had the three
The
categories?
Oh, that was UCLA with
Yeah.
Dr. Lenore Ackerman, and she's also the one that was the lead on the recent GSM guidelines with the AUA.
Oh, okay. That's super cool.
Hmm. Yeah.
So, in that study, would you say of those three subcategories, the women who, was it only on women, by the way?
Yes.
Yeah, okay. The women who specifically were in the bladder category, would be those be the only women who you would actually say should take the supplement?
Yes.
Yeah, right.
Yes.
Okay, that's what I
Yes.
figured. So then as
Yeah.
a pelvic floor PT, I have people come in. They typically do not
Hmm.
have a diagnosis.
Mm-mm.
And by the way, I am very big, we're very big on referring out. We work a lot with doctors. So we are sending their eval out. We send them to the urologist and the urogynes that we know are going to actually do a good thorough job. Um, when do you think, I guess I'm trying to understand clinically how I'm going to utilize this. At some point, I'm starting to realize most people they're all going to respond well to care, but some people respond much
Yeah.
quicker because they have no bladder involvement. It is just mainly the pelvic floor muscle that's involved,
Hmm.
always the nervous system's involved. Some of it is more radiating. We do a lot of pain neuroscience, so even when it is a neuropathic type symptom, they're going to respond well. But then I've got some where I can tell it's more bladder, but I can't tell that until a little bit later in the plan of care. Maybe it's been like
Hmm.
6 to 8 weeks when we've calmed everything else down and I can get more to that centralized understanding of their pain. Um, and then is that when you would say I should maybe decide, okay, now I'm going to add this part in, or would it be smart to add it in right away?
The thing is it can be a waste of money.
That's what I'm thinking. Okay.
Yeah, I mean it really can be. From a clinical perspective, it's probably better afterwards
Okay.
because as you progress, if they sit there and they've done 6 to 8 weeks of treatment and they're still having their bladder symptoms, well, then that is a good time to try the SSAV. But if
Okay.
we try it on the onset, but it's almost like throwing a bunch of supplements at something at once and then which one worked, and are you going to have to just stay on all these for the rest of your life because you just wasted a bunch of money and don't
Yeah.
know what does what.
This is
You
going to be a
start
great, yeah. This is going to be a
one.
great protocol to follow then for those patients that aren't responding fully to just pelvic floor PT, is what I'm realizing.
Yes,
Yeah.
yes, yeah,
Okay.
yeah. That's where the SSAV makes sense. If the pelvic floor physical therapy, you've addressed their hypertonic pelvic floor, you've addressed, their pelvic floor dysfunction, you've assessed and dealt with their neuropathic pain and where it might be radiating from other areas in their body. And they've all done that for 6 to 8 weeks, and then suddenly, but they still have the bladder symptoms. That is the perfect time, because, like I said, you don't want to just add a bunch of things at once. So start there, get down that path, and then that's where the SSAB would make sense.
Okay. Another question I meant to ask you this a while ago when we were talking about when I asked you about the marshmallow root, pre-leaf.
Mhm.
Do you ever use pre-leaf ever? Okay. And is
Yeah,
it
so
safe
we
to use it?
have we have a version of it. It's the
Okay.
exact same. It's calcium glycerol phosphate.
Yeah.
It is yes and no.
Okay.
It's almost like it's almost a better version of Tums,
Yeah,
essentially.
it is.
So so we have two different ones. We actually have calcium carbonate, which we actually put in our SSAV. It is the cheapest form of calcium, but it is the best form at reducing acidity in the
You
body
said that. You said you
itself.
put it in there. I heard you say you put it in there to make it more alkaline.
Yes.
Okay.
And so we have this calcium and vitamin D3, calcium carbonate and vitamin D3 that some people like better than the calcium glycerophosphate, because the whole point of the calcium glycerophosphate is to reduce the acidity in food and drinks versus the body itself, which is more the calcium carbonate and the vitamin D3. But the biggest thing you have to worry about is constipation.
Yep.
You always need equal parts magnesium to equal parts calcium in the body. If you're popping it like candy to be able to eat foods, you need to make sure that you're also popping a little bit of magnesium like candy
Yep.
at the same time, because otherwise you'll get that constipating effect, and then you'll be like, this pelvic floor physical therapy isn't working for me. My abdomen is in so much pain. You'll be like, you're constipated.
Yep, I love that. So anyone listening who has bladder symptoms, I just want to, so something that a lot of pelvic floor PTs will recommend is something called marshmallow root tea or supplements. The tea is way better, but a lot of people
Yes.
aren't compliant with the tea because you have to make it. So you can take the supplement. Again, it's not as bioavailable as the tea is.
Mm-mm.
Um, Another thing that I always recommend is pre-leaf. That's what we're talking about right now. And so pre-leaf
Yeah.
is a supplement you can take, and I don't recommend taking it all the time. And I'm happy you
Mm-mm.
clarified that, Heather. If you take it all the time, it will constipate you. So if you are going to rely on it all the time, please take magnesium with it because we do not need constipation on top of this. That'll make your bladder symptoms through the roof. That'll create so many
Mm-hmm.
more problems that we don't need. Um, but I use pre-leaf as a flare preventative. And so I say, hey, if you're gonna go, because even when people are dealing with IC, they still will go out with their girlfriends and they'll have a drink, or they still will engage in sex or masturbation, or the things they know that they'll have some chocolate, like things they know that are gonna flare them. Um, or go eat some pizza, right? So they're gonna do things that
Mm-hmm.
are gonna flare them. So I'm like, hey, if you're gonna do these things that you know are going to flare you, that's okay, but take a pre-leaf in
Mm-hmm.
anticipation just to kind of like balance that out. So I was just curious if that was okay to take that with your supplement. I mean, with your,
Yes,
yeah.
yes, because we actually sell it ourselves. We
Okay.
have our own calcium glycerophosphate that we
Okay.
sell that has our SSAV in it to enhance the bioavailability.
All
So
right,
we
cool.
also have that as well, but you can also, just FYI, you may not need that specifically for that. So I actually have interstitial cystitis myself.
Ah, okay.
And I had it, what started this company was my aunt had it.
Mhm.
And so, we always think that there's a genetic component, but who knows? We've never been able to prove that. But it's definitely one of those things where I actually pop a few SSAV before I'm going to go have drinks with my girlfriends.
So that's
And
what you said that when you said that, because you said there's a flare protocol. So I was like, oh, you're using this. My brain went, oh,
mhm.
you're using this versus like pre-leaf.
Yes, and then you don't have the constipating effects as much because there's only 20 milligrams of calcium carbonate per capsule,
Mhm.
and the daily recommended value is like between 1200, right around 1200 milligrams per day from the NIH.
Okay.
So that means that this is a negligible amount to just pop like a few extra right before you go and have drinks with a girlfriend, right before you have sex. And then after sex, one of the best things is you've got to think that sperm is alkaline. It's,
Yep.
and your vaginal microbiome is acidic. And so you need to replace that acidity. So another option in toolbox that we have available in your toolbox is we have Aloe, which is our lubricant, but it's an FDA cleared sexual lubricant and vaginal moisturizer. So you
Okay.
can just insert that just to keep the tissues healthy and just kind of help reset that biome. So it is isoosmolar at 308. Vaginal microbiome should be osmolality should be 290 plus or minus 80 points. And then we've got 4.5 pH. So it's acidic the
Yeah.
way it should be, where we've got sperm at 7, which is, 7 or 8, which is going to be very alkaline. And so you can reset that. And then we also have Aloe fresh wipes. Now, these are just on the go. They're great I have in my bathroom, purse, car, take your pick, desk at my office. And these are great just if you feel any type of irritation, burning, anything like that. They're just naturally. Sometimes I'll actually just put them inside my underwear, which I've done before, after sex, and I'll wipe with one and leave one there to
That's like
help.
especially if you're especially when they're having like a flare, that would be nice probably for the underwear.
Yes, yes, and then calm that irritation after sex. It's great to just it's got lactobacillus in it, it's got aloe in it. It's just made of a viscous bamboo, so literally it's biodegradable. And you can just wipe with that on the go or whenever you need.
Super cool. All right.
Yeah.
Well, thank you, Heather, for all of this. This was super great to talk about this. When your bio got sent over, I was like, oh, this was right up our bread and butter. I love talking about interstitial cystitis because there's just not enough people who understand it and talk about it and advocate for it. And
Hmm.
so many women are suffering, women and men. I hate to just say
Yes.
women because men suffer
Yeah.
with it too. We treat a lot of men at our clinic, and
Hmm.
honestly, men are, I feel like, even further misdiagnosed
Oh
with
yeah.
it. And they're actually harder
Hmm.
to treat, I would say, than my females
Yes.
are because it's harder to get to their tissues than my
Yeah, the anal manipulation isn't like the most, ideal route that they like to proceed down, but
Yeah, well, it's
most,
harder to get to the bladder. It is because
yeah.
there's more tissues in the way. The prostate's in the way. It's easier to work on women.
Hmm.
So, but anyways, IC it's something that I'm hoping that the research continues to move forward on, and we start to see a huge shift clinically in the medical profession and the understanding on it, and pharmaceutically, I hope we see a shift in how we're able to treat it, and we get rid of things like Elmeron. So this was
Yes.
just so helpful. Thank you so much for your expertise. And
Yeah.
anybody who's listening, if you guys have any questions, is there a way that they can get a hold of you or talk with you and your company?
Oh, yeah, definitely. So they can check us out. Like I said, our website is desertharvest.com. They can check us out on Instagram at Desert Harvest Aloe Vera. And you're even welcome to message me at Florio is my Instagram handle. And I'm always more than happy to answer questions.
Perfect. Bye all. We'll see you at the next podcast
Bye.
episode. We are Dr. Molly Hart and Dr. Katie Schubert, and you've been listening to Sex on the Floor podcast. We really hope that you enjoyed this episode. If you have any questions and want to get in contact with us, you can follow us on Instagram at Dr. Molly Hart and at Dr. Katie Schubert, on Facebook at Pelvic Balance PT and at Dr. Katie Schubert. And for more information about us on our websites, you can find us at pelvicbalancept.com and at drkatieschubert.com.